Hi, I'm Leggie Ballesteros, a practicing obesity management PA at Gonzalo Medical Group in San Antonio, Texas. I'm back to talk with you about individualizing treatment for our patients with obesity. Let's discuss Rosalinda, a 62-year-old woman. Her weight is at 202 pounds and her body mass index is 35. Her waist circumference is 42 inches. I typically measure that waist circumference to better understand and document a patient's body composition and adiposity. Her blood pressure is 142/85. Lipids are within normal range and she's already taken a statin. Her resting heart rate is 80 beats per minute, respiratory rate is 21, and her eGFR and liver numbers are normal. She has a history of peripheral arterial disease, which was diagnosed 2 years ago, with her ABI at a 0.8. She received GDMT for her peripheral arterial disease. When I asked for permission to discuss her weight in the past, she was hesitant, but on her last visit, this changed. Seeing her friends use obesity medications with success motivated her to improve her own health. She has started to adjust her nutrition and take water aerobics with a friend. I was excited for her. Her insurance didn't cover treatment for obesity. She had already called to ask. But she still wanted to know her options. So we reviewed all the FDA-approved medications, their pros and cons to treat obesity. Fortunately, she didn't have any contraindication for any of them. Her primary concern, in addition to weight reduction, were to avoid those major adverse cardiovascular events due to her history of severe peripheral arterial disease. She wasn't concerned about injections, and she had a really realistic goal for reducing her blood pressure and losing 25 pounds. That's approximately 13% of her body weight. In the end, we decided to go with semaglutide. I gave her the option between a daily oral formulation or the weekly injection. She chose the injection because of the weight reduction data, and we had a lengthy discussion on initiating therapy. More on this in my next video. The indication to reduce the risk of MACE, in addition with the body weight reduction, was compelling in her case, because the clinical data supported multiple potential successful outcomes for her. We are currently in the process of getting that prior authorization approved for MACE prevention and obesity management. It's important that you work with your prior authorization department for insurance companies to understand coverage for these comorbidities. Let's revisit a few things in that case. When considering which medications to offer patients, I take 3 main steps. First, I check to see if the patient has any complications or condition that could rule out specific medications or even an entire class. For instance, patients that have had medullary thyroid carcinoma or multiple endocrine neoplasia type 2 should not be treated with GLP-1s. We should also consider whether they have a history of gallstones, pancreatitis, gastroparesis, and in some patients, bowel obstructions, because these may actually rule out the medications for them. Then I think about the conditions that are known to be improved by these medications. In the case of Rosalinda, her history of peripheral artery disease prompted me to consider semaglutide because of its indication to reduce the risk of MACE in some patients. Once I've considered the comorbidities, I then work with the patient to understand their preference and financial situation so we can choose the best path to get started. I like to provide a few options to patients to consider because each treatment plan always has its pros and cons. For Rosalinda, we discussed 3 plans. Plan 1 was to try to get a prior authorization for that injectable semaglutide due to the risk of MACE. Plan 2, which became our primary backup plan, was to use the oral formulation of semaglutide because even if we couldn't get that prior authorization, it was manageable within her financial situation. Plan 3 was to consider orforglipron, which doesn't have a MACE indication, but it could still help her reach that body weight and is the choice that she could afford. Financial reasons are not the only reasons we like to have backup plans. Sometimes patients do not stay on a medication because they cannot tolerate it. Other times, patients may not be responsive to a medication. As new medications come out into the market, we're seeing some great numbers, but the reality is that there's still a range of responses. In fact, some data suggests that between 10 and 20% of patients have little to no response on GLP-1 medications. It doesn't mean we give up, it just means we consider another option to help our patients achieve improved health. In the case of Rosalinda, we might try 1 or 2 GLP-1 medications, but if she doesn't respond, we might actually consider adding a non-GLP-1, such as phentermine topiramate or bupropion naltrexone as well. I have the opportunity to provide my patients with the education they need for the best chances of success. I hope you'll join me in my last video, where I'll discuss patient education. See you there.